Section 1. Management. Initial to definitive.
Imagine a patient comes in with progressive dysphagia. Your absolute first move, ABCs. Make them NPO if there's any aspiration risk and start those IV fluids. Definitive management? Well, that completely depends on the cause. Let's say it's achalasia. Your initial step is an endoscopy to rule out cancer. But the definitive fix is a laparoscopic Heller myotomy with a partial fundoplication, or a POEM procedure. For GERD, we start simple with lifestyle tweaks and PPIs, but if it's stubborn or complicated, we're looking at a surgical fundoplication. Moving on to Barrett's esophagus, you want to hit them with PPIs and put them on strict surveillance. If dysplasia pops up, definitive management means endoscopic eradication, or in super highly selected cases, an esophagectomy. And finally, for a hiatal hernia, we start with PPIs for the sliding type. But listen, if it's a symptomatic paraesophageal hernia, they need a definitive surgical repair and fundoplication.
Continuing that management flow, let's hit some massive emergencies and major pathologies. For esophageal cancer, your initial goal is optimizing nutrition and completing staging, which definitively leads to neoadjuvant chemoradiotherapy followed by an esophagectomy. Now, what about Borjeev syndrome, that spontaneous rupture? Initial steps are immediate NPO, broad-spectrum antibiotics, and straight to the ICU. You are fast-tracking them to an emergency surgical repair. Got a corrosive injury? Secure the ABCs, keep them NPO with IV fluids. Definitively, they might need stricture dilatation or even a total esophageal replacement down the line. If it's a foreign body, check the airway immediately, then go in for endoscopic removal. And for bleeding varices, you've got to memorize this exact sequence for your exams. Resuscitate first, give vasoactive drugs, and then do endoscopic band ligation. Keep tips in your back pocket if that fails.
Section 2. The investigation ladder.
Exams love testing the difference between your first test and the gold standard. For undifferentiated dysphagia, your initial investigation is an upper GI endoscopy, but the gold standard, that's an endoscopy with a biopsy to really look at that tissue architecture. For achalasia, you'll often start with a barium swallow to spot that classic shape, but the absolute gold standard to lock in the diagnosis is high-resolution manometry. For GERD, a simple PPI trial is your starting point, but the gold standard is 24-hour pH monitoring. With Barrett's esophagus, you start with an endoscopy, but again, the gold standard requires that biopsy to actually prove the cellular changes. And for suspected cancer, while your initial step is an endoscopy with a biopsy, the gold standard for full staging means you need an endoscopic ultrasound, or EUS, for the T stage, combined with a PET CT scan to check for distant disease.
Let's finish up this diagnostic ladder. For Borjeev syndrome, a plain chest X-ray might be your quick initial look, but the gold standard, and please, this is a massive exam pearl, is a CT chest using water-soluble contrast. Never, ever use barium here. If barium leaks into the mediastinum, you are looking at severe, life-threatening mediastinitis. Moving to corrosive injuries, an endoscopy between 12 and 24 hours is your initial step, and the upper GI endoscopy remains your gold standard for assessing the damage. For a hiatal hernia, a barium swallow beautifully outlines the anatomy initially, but endoscopy is the gold standard to check out the mucosa. And for varices, endoscopy is both your very first step and your gold standard for diagnosis and treatment all at once.
Section 3. Cancer, TNM staging, and management.
Okay, mastering anatomical depth is absolutely key here. Let's climb the layers of TNM staging. TIS is carcinoma in situ. It hasn't breached the basement membrane at all. T1 invades the mucosa or submucosa. T2 digs deeper, right into that thick muscularis propria. T3 breaks out into the adventitia. Now the T4 stage is where it gets critical. T4A invades resectable adjacent organs like the pleura, pericardium, or diaphragm. But T4B, that means it invades unresectable structures. We're talking the aorta, the vertebral body, or the trachea. Add to this N0 to N3, which just tells us about increasing regional lymph node involvement, and M0 versus M1, which simply differentiates no distant metastasis from active distant metastasis.
And this brilliantly illustrates how staging dictates our entire management flow. For TIS, that carcinoma in situ, we can often just manage it with an endoscopic mucosal resection, with or without ablation. For stage 1, which is localized disease, we go straight to a surgical oesophageectomy. But look at step 3. This is huge. Once you hit stage 2 or 3, the whole paradigm shifts. The standard of care demands neoadjuvant chemoradiotherapy first to shrink the tumor, and then you do the oesophageectomy. Finally, for stage 4 or M1 disease, curative surgery is completely off the table, and we pivot entirely to palliative therapy.
Section 4. Palliative Care Solutions.
When a cure isn't possible, optimizing the patient's quality of life becomes our absolute highest priority. Let's map specific problems directly to their best palliative fixes. If the main issue is severe dysphagia, the best palliation is placing a self-expanding metal stent, or SEMS, to mechanically hold that esophagus open. For tumor bleeding, we rely on localized radiotherapy or targeted endoscopic therapy. For pain, you strictly follow the WHO analgesic ladder. If nutrition is failing, we bypass the esophagus completely with a feeding jejunostomy or a PEG tube. For dangerous airway compression from the tumor's bulk, an airway stent is literally a lifesaver. For systemic metastatic symptoms, palliative systemic chemo, maybe with immunotherapy, is the way to go. And finally, if the patient just has a really poor performance status, the definitive approach is comprehensive best supportive care.
Section 5. Rapid Disease Differentiation.
This is where we train your brain to spot clinical differences instantly. First up, achalasia versus cancer. Both cause dysphagia, right? But radiologically, achalasia gives you this smooth bird beak tapering, which you confirm with abnormal manometry showing a failure of relaxation. Cancer, on the flip side, shows up as a ragged, irregular narrowing on imaging, and the diagnosis absolutely hinges on a positive tissue biopsy.
Next up, GERD versus Barrett's esophagus. GERD is primarily a clinical functional reflux disease causing symptoms like heartburn. But Barrett's, that is a strict anatomical and cellular diagnosis. Barrett's is defined by that dangerous precancerous shift where normal squamous epithelium turns into columnar intestinal metaplasia. That metaplasia is the critical difference you need to remember.
So, why does this next distinction matter clinically? Sliding hernias versus paraesophageal hernias. Sliding hernias, where the GE junction slides up, are incredibly common and usually just cause some reflux. But paraesophageal hernias, that's where the gastric fundus herniates up alongside the esophagus, and they carry a terrifying, life-threatening risk of ischemia and strangulation. That is exactly why paraesophageal hernias require definitive surgical repair.
Here's another vital difference in anatomical depth. Both of these happen after severe vomiting. But Borehave syndrome is a catastrophic full-thickness transmural rupture of the esophagus that leads to massive mediastinal contamination. Mallory-Weiss, on the other hand, is merely a superficial mucosal tear right at the GE junction, and it usually stops bleeding on its own. Transmural versus mucosal, that's your exam key right there.
And to wrap up our differentiation, let's look at strictures. The radiological golden rule here is so simple. A benign stricture, maybe from chronic acid reflux or swallowing a corrosive substance in the past, will show a nice, smooth, symmetrical tapering. But a malignant stricture from an invasive tumor, that will almost always show up as an asymmetric, irregular narrowing.
Section 6. Last-minute exam pearls.
Okay, lightning round. I want you to mentally answer these high-yield questions a split second before I give you the answer. Ready? What's the most common esophageal cancer worldwide? It's squamous cell carcinoma. What's the most common in Western countries? That's adenocarcinoma. What is the absolute gold standard for diagnosing achalasia? High-resolution manometry. And finally, what's the best initial test for undifferentiated dysphagia? Upper GI endoscopy. Did you get them all? Let's keep it moving.
What's the most common type of hiatal hernia? It's the sliding, or type I hernia. What's the most feared complication of Barrett's esophagus? Adenocarcinoma. When you do an esophagectomy, what is the best reconstruction technique? The gastric pull-up. What is the precise first treatment sequence for a variceal bleed? Resuscitation, then vasoactive drugs, then endoscopic band ligation. And what's the most common site of foreign body impaction in the esophagus? The cricopharyngeus, which is your upper esophageal sphincter.
Let's bring it home. What's the best treatment for Borehave syndrome? Emergency surgical repair. What is the most common long-term complication of a corrosive esophageal injury? An esophageal stricture. So the crucial point is, what's the highest risk Zargar grade on endoscopy for those corrosive injuries? A grade 3 injury. And finally, what is the preferred standard of care treatment for locally advanced, resectable esophageal cancer? Neoadjuvant chemoradiotherapy, followed by an esophagectomy.
Section 1, Diagnosis and Initial Management. We are kicking things off right at the front lines of clinical presentation.
Okay, let's map out our investigation ladder. You might notice a pattern right away, right? Endoscopy is kind of your undisputed workhorse here. It serves as both the initial and the gold standard for peptic ulcer disease, bleeding ulcers, and gastric cancer. But, there are crucial exceptions. Suspect a perforation? Well, you need an erect chest x-ray first to catch that free air under the diaphragm, though a CT abdomen actually remains the true gold standard. For each pylori, we start non-invasively. Think a ureobreast test or stool antigen, but we rely on an endoscopic biopsy for absolute confirmation. What if a patient has a gastric outlet obstruction? You'll start with an endoscopy, sure, but the gold standard requires that endoscopy plus a biopsy to definitively rule out malignancy. Oh, and for a GIST, a CT abdomen spots it initially, but you absolutely need histopathology looking for that specific CD117 marker to clinch the diagnosis.
So bridging the gap between initial resuscitation and an actual cure requires some exact stepping stones. For uncomplicated PUD, we start with PPIs and eradication, reserving surgery only if things go sideways. But if it perforates, immediate resuscitation, IV antibiotics, and an NG tube pave the way for a definitive Graham-Omental patch. For a bleeding ulcer, you gotta resuscitate and give IV PPIs up front, then definitively manage with endoscopic hemostasis with or without surgery. Gastric outlet obstruction, that needs NG decompression and fluids right away, followed definitively by endoscopic dilation or surgery. For gastric cancer, prioritize nutrition and staging up front before diving into perioperative chemo and a gastrectomy. Now, rarer conditions have their own unique pathways. A GIST gets a staging CT followed by resection and possibly imatinib. A gastric volvulus actually demands urgent resuscitation and NG decompression before you surgically reduce and fix it with a gastropexy. A bezoar initially gets endoscopic fragmentation leading to full removal. And finally, Menetrier disease starts with nutritional support, keeping a gastrectomy in your back pocket for selected cases.
Moving right along to Section 2, gastric cancer and classifications. We are shifting our focus to the real heavy hitter of surgical exams. Let's trace the algorithmic workup for gastric cancer. It almost always begins with those classic clinical red flags, right? Unexplained weight loss and early satiety. That triggers an immediate OGD for direct visualization, plus a biopsy to secure that tissue diagnosis. Once it's confirmed, we immediately pivot to staging with a CT of the chest, abdomen, and pelvis to hunt for any gross disease spread. Now, if that initial CT doesn't show gross spread, we meticulously advance the workup. In selected patients, an endoscopic ultrasound, or EUS, provides incredibly precise local T staging. Next up, a staging laparoscopy is absolutely vital to rule out occult peritoneal disease that scans might just miss. All these findings are then brought to the MDT, the multidisciplinary team discussion, to formulate an airtight final treatment plan.
You know, T and M staging is a high-yield guarantee on exams, so let's track the tumor's invasion literally from the inside out. T1 is superficial, just hanging out in the mucosa or submucosa. T2 digs deeper into the muscularis propria. T3 breaches the subserosa. T4A breaks right through the serosa itself, and the dreaded T4B invades entirely separate adjacent organs. Now for nodes, involvement scales from N0 up to N3, tracking increasing regional node spread. And finally, M0 versus M1 simply distinguishes the absence or presence of distant metastases. Pretty straightforward, right?
So, how does that stage actually dictate our definitive management? Well, it's basically a ladder of escalating intervention. Early T1 gastric cancer can sometimes be cured with localized endoscopic resection or surgery. For stage I disease, the gold standard steps up to a gastrectomy with a D2 lymphadenectomy. Once we hit stage 2 or 3, we really have to bring in the systemic firepower, meaning perioperative chemotherapy combined with surgery. By stage 4, our clinical goals shift entirely to maximizing quality of life through palliation. Okay, eponyms are classic exam traps. Let's clearly define these important classifications. The Lauren classification gives us two histological flavors, intestinal versus diffuse types. The Borman classification grades the gross visual appearance. Type 1 is polypoid, type 2 is ulcerated, type 3 is an infiltrative ulcer, and type 4 is linitis plastica, that rigid leather bottle stomach. For bleeding ulcers, we use the Forrest classification, grading from IA, spurting hemorrhage, to IB, oozing, all the way down to 2A, visible vessel. Remember, GIST risk isn't just about size. It's actually a combination of tumor size and the mitotic count. And TNM? Well, as we just saw, that's purely T plus N plus M. All right, Section 3, surgery and reconstruction steps. Once we've staged the disease, how do we physically treat it? Let's dive straight into the operative theater. Visualize stepping into the OR for a distal gastrectomy. We systematically progress through the abdomen. We begin with wide mobilization of the stomach, move to highly specific vessel ligation, and execute a radical D2 lymphadenectomy to sweep the nodes.
Only then do we perform the actual distal resection, finalizing the procedure by reconstructing the GI tract.
Now contrast that with a total gastrectomy. Notice the vital differences here. We start with mobilization and proceed straight into that extensive D2 lymphodectomy, completely skipping the distal vessel ligation step before taking the entire stomach. Crucially, because the stomach is entirely gone, we must conclude with a roux-en-y esophagoduodenostomy to safely restore continuity. To really anchor this, you must pair the operation with its exact anatomical reconstruction. If you perform a distal gastrectomy, you've got options: a Billroth 1 gastroduodenostomy or a Billroth 2 gastroduodenostomy. But if you take the whole stomach in a total gastrectomy, your standard definitive reconstruction is always the Roux-en-Y, no exceptions.
Moving on to Section 4, Complications and Palliation. Unfortunately, not every clinical scenario ends in a straightforward cure. Let's track the natural, untreated progression of peptic ulcer disease. It starts as a simple ulcer, right? But it can quickly progress to bleeding, which is by far the most common complication. If the ulcer erodes entirely through the wall, you get a perforation, which is the most lethal acute event. Chronic, unmanaged ulcers will eventually either penetrate deep into adjacent organs or heal with dense scarring, ultimately causing a gastric outlet obstruction. Now, effective palliative care means matching the specific clinical burden with the absolute right intervention. If a tumor causes a gastric outlet obstruction, or GOO, we relieve it with a gastroduodenostomy or an endoscopic stent. If the tumor is bleeding, we target it with endoscopic therapy or localized radiotherapy. We conquer malignant pain systematically using the WHO analgesic ladder, and we combat malnutrition through targeted enteral feeding. For widespread metastatic disease, systemic chemotherapy is the frontline. But, and this is a big one, if the patient's overall performance status is poor, our highest priority shifts entirely to the best possible supportive care.
Finally, Section 5, Rapid Differentiation and Pearls. We're entering the final sprint of this explainer, a high-energy, rapid-fire review to really stress-test your knowledge.
Pay close attention as we blast through these vital clinical distinctions. Gastric versus duodenal ulcers. Gastric ulcer pain gets worse with meals, while duodenal pain is actually relieved by eating. Benign versus malignant? Well, benign ulcers have smooth, regular margins. Malignant ones look irregular and heaped up. Intestinal versus diffuse cancer? Intestinal forms glands, while diffuse is famous for those rogue signet ring cells. Early cancer is strictly confined to the mucosa and submucosa, while advanced breaks that barrier. And finally, as we discussed, Billroth I is a gastroduodenostomy, whereas Billroth II is a gastroduodenostomy.
Okay, we have 17 massive exam pearls to get through, so let's rapid fire the first 11 right now. For malignancies, the most common type is adenocarcinoma, and it absolutely loves to hide in the antrum. For PUD, the #1 cause is H. pylori, and the #1 complication is bleeding. But what causes perforations most often? Duodenal ulcers. If you see air under the diaphragm, suspect a perforated holoviscus immediately and get ready for a gram patch repair. For diagnostics, endoscopy plus biopsy is the gold standard for cancer, while EUS is king for local T staging. Finally, your gold standard lymphodectomy is the D2, and if you're hunting a GIST, look for the CD117 or CKIT marker. Finishing strong with our final 6 pearls. The absolute histological hallmark for diffuse gastric cancer? Signet ring cells. If you see Borman type 4, you are definitely looking at Lenidus plastica. Your go-to reconstruction after a total gastrectomy is a Roux-en-Y, and locally advanced cancer demands perioperative chemo plus that gastrectomy. Now lock down these metastatic nodes. A Virchow node sits up in the left supraclavicular fossa. A Sister Mary Joseph nodule pops up at the umbilicus. And a Krukenberg tumor is an ovarian metastasis that originally started in the stomach.
Investigations and clinical workup. So, flawless investigations are basically the absolute bedrock of surgical success. You simply cannot treat what you haven't accurately diagnosed. Let's methodically walk down what we like to call the investigation ladder. Notice how for literally every disease, we have a starting point and a definitive gold standard. For a small bowel obstruction, or SBO, your initial imaging is an abdominal X-ray, but the gold standard? That's a CT abdomen with contrast. If you suspect strangulation, the CT abdomen is your initial move, but the true gold standard actually relies on operative findings. You have to get in there. Moving down the ladder, a Meckel diverticulum might initially be investigated with a variable CT or ultrasound, but the definitive test is a technetium 99M Meckel scan. For Crohn's disease, you might start with a colonoscopy, but the gold standard is an ilocolonoscopy with biopsy. Small bowel tumors start with a CT abdomen and end with histopathology as the gold standard. For an intracutaneous fistula, the initial CT abdomen is followed by CT fistulography in selected cases. And finally, a perforation initially presents on an erect chest X-ray, but the gold standard is once again the CT abdomen.
And this brilliantly illustrates the step-by-step logic of an SBO workup. It always starts with the classic presentation, right? Pain, vomiting, and distension. Immediately you move to resuscitation, ABCs, dropping a nasogastric tube, and pushing IV fluids. Then you step onto that investigation ladder we just talked about. Initial AXR, followed by the gold standard CT abdomen. The results of that CT allow you to confidently classify the obstruction as simple versus strangulated, which then directly dictates your final decision, conservative management or surgery.
Moving right along to Section 2, Initial and Definitive Management.
Now that we've nailed down the diagnosis, it's time to shift to definitive action. Let's contrast how we stabilize patients versus how we actually cure them. For a general SBO, initial management is always ABCs, an NG tube, IV fluids, and electrolyte correction. Definitive management is surgery, but only if there's strangulation, complete obstruction, or a total failure of conservative treatment. Now, if it's specifically an adhesive SBO, the initial approach is conservative, often called drip and suck, with adhesiolysis serving as the definitive surgery if it comes to that. Contrast this with strangulated bowel. You resuscitate and give IV antibiotics for sure, but they urgently need an emergency laparotomy and resection. Adult intussusception requires resuscitation, followed by surgical resection. And a Meckel's diverticulum, resuscitate first, then perform a diverticulectomy or a segmental resection.
Continuing with our management protocols, small bowel perforation demands resuscitation and antibiotics immediately, followed by an emergency repair or resection. For Crohn's disease, initial medical therapy relies heavily on steroids and nutritional support, specifically reserving surgery for complications. Small bowel tumors absolutely require proper staging before you move to a definitive segmental resection. Now let's unpack enterocutaneous fistulas. Initial management uses the SNAP strategy, that's sepsis, nutrition, anatomy, plan, before attempting any definitive repair. You have to optimize the patient first. Lastly, short bowel syndrome starts with fluids and total parenteral nutrition, or TPN, with definitive management focused entirely on intestinal rehabilitation, with or without a transplant.
All right, Section 3, Classifications and Rapid Differentiation.
So the crucial point here is that you absolutely must know your frameworks. These are the vital classifications that surgeons use every day and that you will be tested on. You've got to know SBO types, which we'll break down in just a second. You need to know the Montreal classification for Crohn's disease. For enterocutaneous fistulas, you have to memorize the output volume cutoffs. Low is less than 200, moderate is 200 to 500, and high is greater than 500 milliliters per day. For bowel trauma, we rely on AST injury grades 1 through 5, and for small bowel malignancy, we always use TNM staging.
Let's look at how SBO classifications strictly dictate clinical action. It's actually a pretty simple matrix. If the obstruction is partial, management is conservative. If it's complete, it usually requires surgery. If the obstruction is simple and the patient is perfectly stable, you manage conservatively. But if it is strangulated, you are looking at a surgical emergency. The classification literally drives the scalpel.
Okay, let's test your rapid differentiation skills. These are the key pathological contrasts you need for exams. Simple versus strangulated SBO. The main difference is the absence of ischemia in simple versus the presence of ischemia and peritonitis in strangulated. Mechanical versus paralytic ileus. Mechanical has a very distinct transition point, while paralytic shows diffuse bowel dilation. Crohn's disease versus ulcerative colitis. Crohn's has skip lesions, UC is a continuous disease. Meckel versus appendix. A Meckel is a true diverticulum, while an appendiceal anomaly or a standard diverticulum is often false. And finally, distinguishing the jejunum from the ileum anatomically. The jejunum has a thick wall with few arcades, while the ileum has a thin wall with multiple arterial arcades. Moving to Section 4, Surgical Timelines and Procedures.
Let's mentally step into the operating room for a second. Here are the 6 precise operative steps for a small bowel resection. First, you gain access via laparotomy or laparoscopy. Second, you identify the pathology. Third, and pay attention because this is the critical make-or-break moment, you must assess bowel viability. Fourth, perform the resection. Fifth, depending entirely on that viability and the patient's stability, you either create a primary anastomosis or bring out a stoma. Finally, step 6 is closure.
Now let's see how this sequence builds when we're specifically dealing with adhesiolysis. You explore the abdomen, and your immediate goal is to identify that transition point we talked about earlier. Once found, you carefully divide the adhesions. But look at step 4. We are right back to assessing bowel viability. If the bowel has been choked for way too long and is non-viable, you proceed straight to resection. All right, Section 5, Oncology and Palliative Care. Shifting our academic focus just a bit to malignant pathologies, here's your rapid-fire TNM staging for small bowel cancer. T dictates the depth of tissue invasion. T1 is mucosa or submucosa. T2 hits the muscularis propria. T3 reaches the subserosa. T4 means the tumor has actually broken through to the peritoneum or adjacent organs. N staging, ranging from N0 to N2, indicates regional lymph node involvement. And M staging is super straightforward. M0 is no metastasis, M1 is distant metastasis.
And that TNM staging, it correlates directly to clinical action. If the disease is localized based on staging, the management is a segmental resection plus lymphadenectomy. If the disease is node positive, you still proceed with surgery, but you typically add adjuvant chemotherapy. However, if the cancer is metastatic, surgery is usually off the table for a cure, and we rely purely on palliative systemic therapy.
Which brings us to palliative care strategies for complex end-stage problems. If a patient has a malignant obstruction, the best palliation is a surgical bypass or a stoma. For pain, you strictly follow the WHO analgesic ladder. Malnutrition is managed with TPN or enteral feeding. A high-output fistula requires really aggressive electrolyte and nutrition management. Metastatic disease is managed with systemic therapy, and if a patient has poor performance status, the most appropriate and, frankly, compassionate route is best supportive care.
And finally, Section 6, High-Yield Exam Pearls.
We have reached the final stretch. Now, what's really interesting here is how perfectly the Meckel diverticulum's rule of twos encapsulates a complex congenital anomaly. It's legendary for a reason. It occurs in 2% of the population. It's located 2 feet from the ileocecal valve. It is typically 2 inches long. It mostly presents in children under 2 years of age, and it contains 2 types of ectopic mucosa. Seriously, burn this into your memory.
Let's drill these first 5 pearls at pace. Quick Q&A style. What is the most common cause of an SBO? Postoperative adhesions. What is the second most common cause? Hernias. What's the gold standard investigation for an SBO? CT abdomen with contrast. What is the most common congenital GI anomaly? Meckel diverticulum. And what is the most common ectopic tissue found in a Meckel? Gastric mucosa.
Continuing the rapid-fire drill, adult intussusception. Remember, unlike in kids, in adults it usually has a pathological lead point. Best treatment for strangulated bowel? Emergency laparotomy plus resection. Most common complication of Crohn's disease? Stricture or obstruction. Initial management of SBO, calling back to what we learned earlier, NG tube, IV fluids, and electrolyte correction. Indications for immediate surgery in SBO, strangulation, perforation, closed-loop obstruction, and peritonitis.
All right, our final set of one-liners. What does SNAPS stand for in intracutaneous fistula management? Sepsis, nutrition, anatomy, plan. What exactly defines a high-output fistula? An output greater than 500 milliliters per day. And how do you manage short bowel syndrome? Long-term nutritional support, with or without an intestinal transplant.
Management. Imagine you're on call and a patient rolls in. This slide beautifully maps out the strict acute abdomen workup algorithm. It all triggers with that presentation of severe abdominal pain. Immediately, you've got to secure the ABCs: airway, breathing, circulation. Only once they're stable do you sequentially move through a thorough history and physical examination. From there, you draw your labs. We're talking a complete blood count, lactate, liver function tests, and amylase or lipase. Next up on the ladder is imaging, typically a CT of the abdomen, and you'll absolutely want to add a CT angiography if you even suspect ischemia. This step-by-step pathway safely guides you to a definitive diagnosis, which then dictates whether your patient needs medical or surgical management.
Now, here's where it gets really interesting. Notice the critical contrast between your initial stabilizing steps and the definitive cause-specific treatments. For a general acute abdomen, your initial move is the basics. ABCs, keeping the patient NPO, IV fluids, analgesia, maybe an NG tube, and antibiotics if there's sepsis. The definitive step is, of course, cause-specific surgery. But let's look at acute mesenteric ischemia, or AMI. Here, you've got to immediately start IV fluids, broad-spectrum antibiotics, and crucial IV heparin. This is a bridge to your definitive treatment, revascularization, with or without a bowel resection. Now, for mesenteric venous thrombosis, you start with IV heparin and definitively treat with ongoing anticoagulation, only taking them to the OR if there's actual infarction. For NOMI, that's non-occlusive mesenteric ischemia, You initially have to optimize perfusion and treat the underlying shock before definitively using intra-arterial vasodilators. And finally, for chronic mesenteric ischemia, initial nutritional support sets the stage for definitive endovascular angioplasty, stenting, or a bypass.
Moving right along to Section 2, Investigations and Diagnostic Ladders. So the vital takeaway here is understanding the gap between that very first test you order and the ultimate gold standard. For a general acute abdomen, your initial tests are the standard CBC, CRP, LFTs, amylase, lipase, and lactate. But the gold standard confirming everything is a contrast CT of the abdomen. Now let's focus heavily on AMI. The initial test you're looking at is serum lactate, but let me be clear, the absolute gold standard to confirm it is a CT angiography. For mesenteric venous thrombosis, you might kick things off with a standard contrast CT, but you really want a CT venography or angiography to be 100% certain. And lastly, for chronic mesenteric ischemia, a duplex ultrasound is a fantastic non-invasive initial check, but again, CT angiography remains your undisputed gold standard.
Section 3. Ischemia Classifications and Staging.
If you want to crush your exams, you must pair the 4 classifications of acute mesenteric ischemia with their most common causes and targeted treatments. First up, an arterial embolism. This is most commonly caused by atrial fibrillation, and the treatment is an embolectomy, with or without resecting the bowel. Second, we have arterial thrombosis. This usually stems from underlying atherosclerosis, meaning you'll need to do a revascularization. Third, mesenteric venous thrombosis is driven by a hypercoagulable state, so your primary weapon of choice here is anticoagulation. Finally, non-occlusive mesenteric ischemia, or NOMI, is caused by a low-flow state like profound shock. The treatment for this isn't a mechanical surgical fix. It's purely medical. You have to restore systemic perfusion.
Let's pause for a quick vital definition. You absolutely have to commit this one exactly to memory. Abdominal compartment syndrome is strictly defined by an intra-abdominal pressure, an IAP, greater than 20 millimeters of mercury, combined with new organ dysfunction. Listen, if you don't have both of those pieces, you do not meet the strict definition.
Additionally, as you organize your mental framework for all this, just keep these standard classification systems filed away. Remember those 4 distinct AMI mechanisms we just covered: embolus, thrombosis, venous thrombosis, and NOMI. And for trauma scenarios involving the abdomen, note that bowel injuries are staged using the AAST system. This scales all the way from a grade 1 minor hematoma right up to a grade 5 massive devascularization. All right, Section 4, Surgery Timelines and Damage Control. Let's head into the OR.
Check out the methodical sequence here for acute mesenteric ischemia. It all kicks off with your CT angiography. Now, if there's peritonitis, you proceed straight to a laparotomy. But here is the absolute key to this entire pathway. You must perform the revascularization step before assessing bowel viability. Why? Well, because a segment of bowel that looks completely dead might actually pink up once you restore the blood flow. After you revascularize, then you assess viability, resect any clearly non-viable bowel, and plan for a second-look laparotomy about 24 to 48 hours later.
In stark contrast, what if your patient is physiologically unstable on the table? We abandon that definitive timeline completely and shift entirely to damage control. Your priority literally flips to immediate survival. You rapidly control contamination, then you control bleeding, perform a quick temporary abdominal closure, and immediately transfer that patient for ICU resuscitation. Definitive surgery? That's postponed until they are actually stabilized. Section 5, Rapid Differentiation and Palliation. Let's get into that rapid-fire mindset.
In a high-pressure situation, like the Viva room, the clinical contrasts are incredibly stark. If a patient presents with sudden severe pain, you should immediately be thinking acute mesenteric ischemia. But if they're complaining of postprandial pain, meaning pain right after they eat, combined with weight loss, you've got to shift your thinking to chronic mesenteric ischemia. Furthermore, sudden onset pain in a patient with known atrial fibrillation absolutely screams embolism. Conversely, if they have a long documented history of atherosclerosis, you should highly suspect a thrombosis.
Building on that, differentiating arterial from venous ischemia really dictates your next move. Arterial generally requires mechanical revascularization, whereas venous is primarily treated medically with anticoagulation. And here's a classic diagnostic pivot you'll face. You must rapidly differentiate the colicky, coming and going pain of a mechanical bowel obstruction from the relentless, classic pain out of proportion to physical examination that truly defines ischemia.
Now, let's be real. Sadly, not every case can be surgically salvaged, so let's look at the best palliative care options. For non-operative chronic mesenteric ischemia, you want to focus heavily on nutritional support and pain control. For extensive unresectable bowel infarction, where there is just too much dead bowel to sustain life, the standard is best supportive care. And for advanced malignancy causing a mechanical obstruction, a selective surgical bypass or forming a stoma can often offer the best palliation for the patient's quality of life.
Okay, let's wrap this up with Section 6, Last-Minute Exam Pearls. You want to pin down these exact etiologies for your exams. The most common surgical cause of an acute abdomen overall is, no surprise, acute appendicitis. However, the most common vascular cause is acute mesenteric ischemia. Digging a little deeper into AMI, the most common cause is a superior mesenteric artery, or SMA, embolism. Unsurprisingly, the SMA is the most commonly affected vessel overall. And finally, the most common cause of NOMI is generalized shock or a low-flow state.
For classic features and investigations, never forget that the gold standard test for AMI is CT angiography. The absolute classic presentation you'll see in question stems is pain out of proportion to the physical exam. A raised serum lactate is your earliest lab clue, though. And this is a big caveat. Be careful, because it can be totally normal early in the disease process. Lastly, the absolute best predictor of actual bowel infarction is either the presence of peritonitis on exam or just direct visualization of non-viable bowel at surgery.
On the treatment front, your initial anticoagulation go-to is IV unfractionated heparin, assuming it's not strictly contraindicated. The definitive treatment of arterial AMI is urgent revascularization, with or without that bowel resection. For mesenteric venous thrombosis, stick with your anticoagulation. And the overarching golden rule for this entire pathology, any delay in diagnosis inevitably leads to a rapid cascade of bowel gangrene, sepsis, and death.
Before we test you, lock this specific triad into your visual memory for chronic mesenteric ischemia. It's a chain reaction of three distinct things. Postprandial pain, which leads directly to food fear, because the patient associates eating with pure agony, which then naturally results in progressive, significant weight loss.
To wrap up this intensive explainer, let's test your clinical reasoning with one final, absolutely crucial question based on the surgical timelines we covered earlier. What is the primary indication for a second-look laparotomy? Take a second to think about what we do after we revascularize the bowel.
The answer is questionable bowel viability. You go back in 24 to 48 hours to see if that sketchy border zone tissue actually survived after getting its blood supply back. Section 1. We're starting our masterclass at the very beginning with the patient presenting to the ward. Our entire focus here, immediate triage and nailing that diagnosis.
Let's track the shift from a quick initial scan, when that 2 a.m. pager inevitably goes off, to the definitive gold standard. For a suspected large bowel obstruction, or LBO, an abdominal X-ray gets things moving, right? But the gold standard is actually a CT of the abdomen and pelvis. Colorectal cancer, start with a colonoscopy, but you absolutely need a biopsy for definitive proof. Diverticulitis relies heavily on the CT abdomen for both your initial checks and for confirming any nasty complications. Suspected volvulus starts with an X-ray, but moves quickly to a CT or a sigmoid scope. For ulcerative colitis, again, scope plus biopsy is king. Now, if you suspect ischemic colitis, start with a CT, but you'll want to move to a colonoscopy once the patient is stable. And finally, for toxic megacolon, an X-ray starts to work up, but clinical correlation plus serial imaging is your ultimate gold standard.
It's fascinating to contrast stabilizing the patient versus actually curing the disease. Think about the anatomical difference in volvulus, for example. Sigmoid volvulus gets resuscitation and endoscopic untwisting before elective surgery, but cecal volvulus, resuscitate them and then it's straight to a right hemicolectomy. For a colonic perforation, you resuscitate, blast them with antibiotics, but definitive care is an emergency laparotomy. This logic applies across the board. For LBO, it's ABCs and NG tube and IV fluids before you even think about surgery or stenting. Colorectal cancer needs nutrition optimization and staging before resection. Diverticulitis and ischemia, they start with fluids and antibiotics, escalating to surgery only for complications, recurrent disease, or gangrene. A diverticular abscess might need drainage alongside those antibiotics before a selected elective colectomy. And for toxic megacolon and UC, you start with steroids and fluids, but definitive cure requires a subtotal colectomy or a total proctocolectomy if they just aren't improving.
Let's map out the exact chronological workflow for a suspected colorectal cancer workup. A patient presents with altered bowel habits or bleeding per rectum. What's next?
Colonoscopy. Then the biopsy confirms it. After that, you stage with a CT of the chest, abdomen, and pelvis. And note this, if it's rectal cancer, you absolutely must add an MRI of the pelvis for local staging. Next, draw the tumor marker CEA. Finally, all this data goes straight to the multidisciplinary team, or MDT, before a single treatment begins. It's an exact sequence, and you can't skip a step.
Section 2. Now that we have a diagnosis and our workup is complete, let's see how this builds into staging the disease, which is vital before any scalpel is lifted.
You must memorize the exact depth of invasion for the T and the TNM criteria. TIS is in situ, and T1 hits the submucosa. But pay close attention to T2. The tumor reaches the muscularis propria. The absolute second it breaks through that muscular layer and enters the pericolic fat, it becomes a T3. T4A touches the visceral peritoneum, while T4B invades directly into adjacent organs. N handles your regional nodes from N0 to N2, and M is for metastasis, M0 for none, and M1 for distant. Etch that T2 to T3 transition into your brain. Examiners love to use that as a differentiator.
Let's translate those TNM numbers into action with a stage-by-stage management protocol. Stage 1 is straightforward surgical resection. Stage 2 is surgery with possible adjuvant chemo. Stage 3 mandates surgery plus adjuvant chemotherapy. Stage 4 leans into palliation or selected metastasectomy. But there is a massive exception to keep in mind. Locally advanced rectal cancer has a highly unique pathway. Neoadjuvant chemoradiotherapy comes first to shrink the tumor in that tight pelvic space, then surgery, and then adjuvant chemotherapy.
We've got a quick cheat sheet here. Briefly frame these 5 critical classifications as easy points on an exam. Whenever you hear Hinchy, anchor that directly to diverticulitis grading, I through IV. TNM is your modern colorectal cancer staging, while Dukes is the older historical system. The Paris classification describes polyp morphology, and AAST grades colon injuries from I to V. Just strictly associate the name with the disease.
Section 3. We have stabilized and staged our patient. It's time to scrub in. Let's review the strict sequence of operative milestones.
Let's go step by step for a right hemicolectomy. You start with mobilization, but pay very close attention to steps 2 and 3. Vascular ligation and lymph node harvesting, or lymphadenectomy, must occur prior to the actual resection of the bowel. This is a foundational oncological principle. You take the vessels first to prevent shedding tumor cells into the systemic circulation during the resection. Finally, you restore continuity with an ileocholic anastomosis.
Contrast that right-sided procedure with the left hemicolectomy and sigmoid colectomy. The oncological principles remain exactly the same. Mobilization, then vascular ligation, then resection. But think about the final step. Because we are on the left side, we're joining the descending or sigmoid colon down to the rectum, making it a colorectal anastomosis.
Now, what happens in an emergency where an anastomosis just isn't safe? That brings us to the Hartmann procedure. This is a true life-saving operation. You do the resection, but instead of joining things back together, you bring the healthy proximal bowel out as an end colostomy on the abdominal wall. You then safely close off the remaining distal bowel, leaving a rectal stump. A reversal to restore continuity might happen later, but only in carefully selected candidates once they've fully recovered.
Section 4. Not all patients are candidates for curative surgery. So let's shift our clinical reasoning to palliative care and rapid clinical differentiation.
Let's look at direct symptom-to-solution pairings for palliation. If a palliative patient presents with obstruction, the best option is often a self-expanding metal stent, or SEMS, or a diverting stoma. For bleeding, we look at endoscopic therapy or radiotherapy. Pain is strictly managed via the WHO analgesic ladder. For liver metastases, it's systemic chemotherapy with or without ablation. If they struggle with poor nutrition, we utilize enteral or parenteral support, and for overall poor performance status, we focus entirely on best supportive care. It's all about improving the quality of life when a surgical cure is off the table.
These clinical contrasts are absolute gold for rapid differentiation on the wards or in exams. Right-sided colon cancer typically presents with anemia because the bowel lumen is wider and tumors bleed occultly. Left-sided cancer, that presents with obstruction because the lumen is narrower and stool is solid. Ulcerative colitis has continuous inflammation, while Crohn's has skip lesions. Sigmoid volvulus gets endoscopic detorsion, cecal volvulus gets immediate surgery. And don't mix up your terms. Diverticulosis means asymptomatic pouches, whereas diverticulitis means they are actively inflamed. Finally, colon cancer gets surgery first, whereas locally advanced rectal cancer needs neoadjuvant chemoradiotherapy before resection. These are the classic, high-yield contrasts you must know instantly.
We are in the final stretch, Section 5. This is the rapid-fire exam recall where we test everything we've just covered in this explainer. Get ready to lock these facts in.
I want you to pause for a brief second. Think about the anatomy, think about the contamination, and actively recall the answer. What is the emergency operation for a perforated left-sided cancer?
Did you get it? It's the Hartmann procedure, resection, end colostomy, and a rectal stump. Now let's rapid-fire the rest. The most common cause of large bowel obstruction, colorectal carcinoma. The second most common, volvulus. Where does colon cancer most commonly hit? The sigmoid colon. Rectal cancer, the rectosigmoid or upper rectum junction. You already know the gold standard for CRC diagnosis is colonoscopy plus biopsy. Staging is a CT of the chest, abdomen, and pelvis, and local staging for rectal is an MRI of the pelvis. And don't forget your tumor marker, CEA.
Finishing strong here. The most common site for colorectal cancer metastasis is the liver. The definitive curative surgery for ulcerative colitis is a total proctocolectomy. Radiologically, if you hear the coffee bean sign, think sigmoid volvulus. An apple core lesion, colorectal carcinoma. Thumbprinting, ischemic colitis. Tostic megacolon is defined by a colon diameter greater than 6 centimeters. Remember our Hinchey grades for diverticulitis. Hinchey I is a pericolic abscess, 2 is a pelvic or distant abscess, 3 is purulent peritonitis, and 4 is fecal peritonitis. And as we hammered home earlier, locally advanced rectal cancer requires neoadjuvant chemoradiotherapy before surgery.
Let's just dive right into our first pillar, clinical workup and management pathways. Getting that rapid diagnosis and a solid management plan is literally the foundation of surgical practice. So let's climb the diagnostic ladder. Notice how for benign conditions like hemorrhoids, anal fissures, and perianal abscesses, your initial step is entirely clinical, but the gold standard, that actually diverges pretty quickly. Hemorrhoids demand endoscopy, whereas fissures remain a clinical diagnosis. Suspect a fistula? You absolutely must get an MRI of the pelvis to map out that tract. For an abscess, an examination under anesthesia, or UA, is often the go-to. Now, shifting over to oncology for a second, rectal cancer always starts with a colonoscopy, but you definitively need a biopsy. Anal cancer requires a biopsy up front too, but backed by a pelvic MRI. And finally, rectal prolapse relies mostly on a clinical diagnosis, with defecography reserved for those trickier select cases.
You know, the real secret to surgical management is bridging the gap between temporizing the patient today and actually curing them permanently. Take benign anorectal issues, for example. Hemorrhoids start with fiber and fluids, sure, but definitively they require band ligation or excision. Fissures need stool softeners and sitz baths initially, but a lateral internal sphincterotomy is your definitive cure. Got a fistula? You've got to drain the abscess first, but eventually you'll need a fistulotomy. Abscesses demand immediate antibiotics and a mandatory incision and drainage. No way around it. What about prolapse? Reduce it acutely, then fix it for good with a rectopraxy. Now, in the oncology realm, rectal cancer requires nutritional optimization right out the gate before definitive neoadjuvant chemoradiotherapy and surgery. Anal cancer needs a biopsy to start, but here's the kicker. Its definitive cure is actually chemoradiotherapy alone. Finally, fecal incontinence starts conservatively before surgical repair, while rectal trauma strictly follows ATLS protocols initially before you move to definitive diversion or repair.
Let's actually trace the exact chronological patient pathway for rectal cancer. It always starts with that clinical alarm, PR bleeding, or an altered bowel habit. That prompts a digital rectal exam. Step 2 is endoscopy, specifically a colonoscopy with a biopsy to nail down that tissue diagnosis. Step 3 is local staging, which we achieve with an MRI of the pelvis. Step 4 is systemic staging, utilizing a CT of the chest, abdomen, and pelvis, plus drawing a CEA tumor marker. Step 5 is absolutely critical, presenting all of this data to the multidisciplinary team, the MDT. It's only after this collaborative consensus that we execute the final treatments. All right, shifting gears into Pillar 2, we're tackling the crucial oncology tumor staging matrix and patient comfort protocols next. Let's break down these T&M criteria methodically because this is high-yield stuff. T stands for tumor depth. TIS means carcinoma in situ. T1, it's invaded the submucosa. T2 means it has reached the muscularis propria. T3 is a real game changer. It has pushed through the muscularis propria and into the mesorectum. T4A means it has breached the visceral peritoneum, while T4B means it is directly invading adjacent organs. Now, N is for nodes, and 0 means none, going all the way up to N2, which indicates multiple regional nodes are involved. And M is metastasis, M0 is none, M1 means we have distant spread. Remember, it's the depth of invasion that entirely dictates your T stage. So why does all that meticulous staging even matter? Well, because it dictates your entire management strategy. Stage 1, localized disease, goes straight to surgery. But locally advanced stage 2 and stage 3 cancers, they require neoadjuvant chemoradiotherapy before you even think about proceeding to a total mesorectal excision, or TME. Stage 4 disease shifts the goalpost entirely to palliation, maybe with a metastasectomy if it's appropriate for the patient.
Speaking of palliation, in advanced cases, palliative care isn't about giving up. It's actually a highly active, targeted intervention to preserve quality of life. If a tumor is causing an obstruction, we relieve it with a diverting colostomy or a stent. Bleeding? That's controlled with radiotherapy or endoscopy. Pain is managed strictly by the WHO analgesic ladder. Troublesome local pelvic symptoms actually often respond beautifully to palliative radiotherapy. Systemic metastasis is met with chemotherapy. And for a patient whose body can just no longer tolerate treatment, best supportive care becomes the absolute most appropriate and humane strategy.
Okay, let's escalate the complexity and step right into the surgical suite for Pillar 3. We'll look at the chronological timelines for 3 incredibly high-yield anorectal operations. First up, the low anterior resection, or LAR. Step 1 is the mobilization of the colon and rectum. Step 2 is really the oncologic heart of the entire procedure, the total mesorectal excision, carefully dissecting within that holy plane. Step 3 is the actual resection of the tumor. Step 4 is creating the colorectal or coloanal anastomosis, and this is the crucial part that saves the sphincter. Finally, step 5 is often creating a protective ileostomy in selected cases just to let that anastomosis heal safely. Now, compare that to the abdominoperineal resection, the APR. We start off pretty similarly with the abdominal phase for step 1 and the TME for step 2. But here is where the operative flow diverges completely. Because the tumor is too low, step 3 requires a perineal dissection. The entire anal sphincter complex must go. Step 4 is specimen removal, and therefore step 5 inherently demands the creation of a permanent end colostomy.
All right, now for a standard hemorrhoidectomy. Step 1, expose the hemorrhoids. Step 2, ligate the vascular pedicle. Step 3, excise the hemorrhoidal tissue. But step 4, this is vital. You absolutely must preserve the mucocutaneous bridges. If you go in there and excise too much tissue circumferentially, the patient will develop a devastating anal stricture, and trust me, nobody wants that.
Moving right along into our 4th pillar, we're categorizing the specific scoring systems and direct clinical comparisons you're going to see all the time on board exams. You simply must know your eponymous classifications for the boards. It's non-negotiable. For instance, the Gallagher classification is strictly for grading hemorrhoids from grade I up to IV. Next, the Parks classification maps out fistulas based on their relation to the sphincter: intersphincteric, transsphincteric, suprasphincteric, and extrasphincteric. Need to predict the internal tract of a fistula? Goodsall's rule is your go-to geometric tool for that. TNM, as we just spent some time on, is the absolute gold standard for rectal cancer staging. And finally, trauma scenarios rely on the AAST rectal injury scale, which grades injuries from I to V. Let's start the rapid-fire differentiators. The distinction between internal and external hemorrhoids is entirely anatomical. Internal hemorrhoids sit above the dentate line. Because this area is innervated by visceral nerves, they are painless. External hemorrhoids, on the other hand, are below the dentate line. They're innervated by somatic nerves, meaning they are exquisitely painful when they thrombose. So how do you instantly distinguish a fissure from a fistula in a clinical setting? Well, an anal fissure presents as a severely painful mucosal tear. Patients often describe it as feeling like they're passing glass. A fistula in ano, however, presents as a chronic, messy discharging tract, and it actually has minimal acute pain unless it forms an abscess. The main difference between these abscesses is all about depth. A perianal abscess is superficial, angry, and you can see it immediately right at the anal verge. An ischiorectal abscess is deceptively deep. The skin might actually look totally normal at first glance, but the infection is filling up the massive ischiorectal fossa space underneath. Now, this is a fundamental histological difference that alters everything about your treatment plan. Rectal cancer arises from the glandular mucosa, making it an adenocarcinoma. Anal cancer arises from the skin-like lining of the canal, so it is a squamous cell carcinoma. And as we saw when we looked at the surgical timelines, the core operative divergence for rectal cancer boils down to this. A low anterior resection, or LAR, means the sphincter is preserved. An abdominoperineal resection, or APR, means you are committing the patient to a permanent colostomy. Okay, we've made it. We have reached the final and most crucial pillar, the definitive sprint of high-yield one-line exam pearls.
So, are you ready? I want you to mentally lock in your answers before we present this final, dense data consolidation. This is where we tie the whole shebang together for maximum memory retention. Let's do this. Here are your 19 ultimate pearls. Let's hit symptoms and anatomy first. Most common cause of PR bleeding, hemorrhoids. Most common site of anal fissure, posterior midline. What about fistulas? The gold standard for mapping is an MRI of the pelvis, while Goodsall's rule predicts the tract course. And the most common type? Intrasphincteric. Okay, moving to infections. The most common anorectal abscess is perianal. For chronic fissures, your treatment of choice is a lateral internal sphincterotomy. Let's pivot to oncology. Most common rectal cancer pathology, adenocarcinoma. Anal canal cancer, squamous cell carcinoma. Gold standard for rectal cancer diagnosis, colonoscopy plus biopsy, staged locally with an MRI of the pelvis, and tracked systemically with the CEA tumor marker. Operation time, the single most important step for rectal cancer is the TME, the sphincter-saving operation, low anterior resection. The one requiring a permanent colostomy, abdominoperineal resection. How do you treat locally advanced rectal cancer? Neoadjuvant chemoradiotherapy followed by that TME. But remember, the standard treatment for anal cancer is chemoradiotherapy alone. That's the Negro protocol. Finally, hemorrhoid grading. Grade 3 is a prolapse requiring manual reduction, while grade 4 is completely irreducible. Seriously, lock these in. Okay, section 1, immediate and definitive management. Let's dive in.
Now, when it comes to peritonitis, your definitive care is literally a night and day difference based on the source. Let's talk secondary peritonitis. That is a race to the operating room for a laparotomy right after you handle the initial ABCs, give fluids, and start broad-spectrum antibiotics. But contrast that directly with primary peritonitis, or SBP. Your initial move there, IV third-generation cephalosporins and albumin, and the definitive management is entirely medical. You just treat the underlying liver disease, no surgery required. For tertiary peritonitis, you're starting with ICU care, and definitively, you'll need repeat source control if things start going sideways. What about an intra-abdominal abscess? You start with antibiotics, sure, but definitive care means percutaneous drainage or surgery. For abdominal compartment syndrome, ACS, you optimize ventilation and fluids initially in the ICU, which leads definitively to a decompressive laparotomy. And finally, for adhesions causing a small bowel obstruction, initial management is strictly conservative. You know, drip and suck. But adhesiolysis becomes your definitive surgical step if they just aren't improving.
So moving on to the mesentery and omentum, your definitive plan here really hinges on stability and certainty. A mesenteric cyst, it starts with fluids and analgesia, but definitively it requires complete surgical excision. Now look at omental infarction. It is notoriously painful, so your initial care is heavy on analgesia and conservative management. Definitively, you only proceed to surgery if your diagnosis is uncertain or if there are complications. Omental torsion is pretty similar. It starts with supportive care, but often ends up requiring a laparoscopic omentectomy. For mesenteric hematoma, you resuscitate initially. Definitively, you just observe them if they're stable, but you rush to the OR if they're unstable. Mesenteric trauma injuries just follow standard ATLS protocols initially, definitively requiring surgical repair and, hey, possibly even a bowel resection. Lastly, a mesenteric desmoid tumor demands proper staging first, followed by selective surgical resection.
Moving right along, Section 2, Diagnostic Investigation Ladder. In the ER, your initial tools are really just a starting point before you need the gold standard. For general peritonitis, your CBC, CRP, and lactate are going to hint at the problem, but a contrast CT, that gives you the final, definitive answer. For spontaneous bacterial peritonitis, your initial step is a diagnostic acidic tap, and the gold standard diagnosis is confirmed when that fluid shows a polymorphonuclear leukocyte, or PMN, count of exactly 250 per cubic millimeter or higher. That number is crucial. Suspect an intra-abdominal abscess? Ultrasound is your initial go-to. But again, contrast CT is the absolute gold standard. And for abdominal compartment syndrome, it all starts with clinical suspicion, but the gold standard test is objectively measuring the bladder pressure to check that intra-abdominal pressure.
Are you noticing a trend here? For most mesenteric pathologies, contrast CT is pretty much the reigning champ. For both a mesenteric cyst and an omental infarction, you start with an ultrasound, but the gold standard is that contrast CT of the abdomen. But actually, here's a really surprising exception. Omental torsion initially warrants a CT, but the true gold standard diagnosis only reveals itself once you're actually in the OR looking at it with your own eyes. For mesenteric trauma, the initial test is a fast scan to quickly check for free fluid, but the gold standard, assuming your patient is hemodynamically stable, remains a contrast CT of the abdomen.
All right, Section 3, Surgery, Timelines, and Algorithms. Time to scrub in.
Picture this. A patient rolls into the trauma bay with severe peritonitis. First things first, ABCs. Secure the airway, breathing, and circulation. Immediately draw your labs, and critically, check that lactate to gauge perfusion. Next, rush them to the CT scanner. Once you've identified the source of the peritonitis on imaging, you administer the appropriate antibiotics. And finally, achieve source control. That might be through percutaneous drainage, or it might mean taking the patient directly to surgery.
Now, once you actually take that patient to the OR for secondary peritonitis, you always start with preoperative resuscitation and broad-spectrum antibiotics. Access the abdomen via laparotomy or laparoscopy, and then execute the absolute most critical action of the entire procedure: control the source of the infection. Once that's controlled, you perform a thorough peritoneal lavage. Finally, place a drain in selected cases and proceed with closure.
For a mesenteric cyst excision, you explore the abdomen and positively identify the cyst. Next, perform a complete excision. But wait, here is a classic board trap. You have to be prepared for a bowel resection if the cyst's removal ends up compromising the adjacent blood supply. Sometimes it's just an unavoidable necessity. Once that's sorted, you close.
For an omentectomy, laparoscopy is your window. Visually identify the area of infarct or torsion. Resect that affected necrotic tissue, and then you must demand meticulous hemostasis before you even think about closing.
Next up, Section 4, Classifications and Palliative Care. So examiners absolutely love rigid definitions. If they ask you about peritonitis, you must know it classifies into primary, secondary, and tertiary. If they ask about abdominal compartment syndrome, you have to reflexively answer an intra-abdominal pressure greater than 20 millimeters of mercury combined with new organ dysfunction. The Mannheim Peritonitis Index is specifically tested as a prognostic score. And for trauma, you're using the AST Peritoneal Injury Scale, which ranges from grade I to V.
Rapid fire time. For mesenteric cysts, lock in these 6 highly tested types. Think of fluid-based ones like chylolymphatic, enteric, mesothelial, and pseudocyst, or the cellular ones like urogenital and dermoid. And just like with the peritoneum, mesenteric trauma is graded using the ASTG Mesenteric Injury Scale, grades I through V.
Now, when surgery isn't an option, palliation is highly tested. You relieve malignant ascites with repeated paracentesis or by placing an indwelling catheter. For pain across the board, always follow the WHO analgesic ladder. For an unresectable mesenteric tumor, your focus shifts entirely to pain control and nutritional support. And for literally any end-stage or advanced malignancy of the peritoneum or mesentery, the answer is always best supportive care.
Finally, Section 5, Rapid Differentiation and Exam Pearls. Get ready for the hot seat.
Here is the ultimate differentiator for peritonitis. What is the one key difference? Primary peritonitis features absolutely no perforation. We usually see it in cirrhosis. Secondary peritonitis, on the other hand, is strictly defined by a perforated viscus. If the examiner asks you for the difference between these key clinical presentations, don't hesitate. Localized is confined to one area, while generalized peritonitis involves the entire abdomen. Sterile versus infected ascites, this is a strict hard cutoff. Sterile is a PMN count less than 250, whereas infected ascites is a PMN count of exactly 250 cells per cubic millimeter or greater. Abscess versus phlegmon. One is a distinct liquid pus collection, while the other is a solid inflamed mass.
Now for the tricky ones in the mesentery. Let's contrast these. A mesenteric versus an omental cyst simply depends on the location. Mesentery versus the greater omentum. Omental infarction versus appendicitis. Listen, this is the classic trap. Omental infarction mimics appendicitis perfectly with right-sided pain, but it presents with a completely normal appendix on imaging or during exploration. Mesenteric hematoma versus hemoperitoneum. One is a localized bleed in the mesentery, while the other is free blood floating in the intraperitoneal space. Finally, omental torsion versus mesenteric ischemia. Torsion results in localized omental necrosis, whereas ischemia results in actual widespread bowel ischemia. Okay, we've covered the algorithms and the mimics. So, what are the absolute highest yield one-line facts that will literally save you on exam day? Let's rapid fire through them.
Treat this like a lightning recall quiz. Most common cause of secondary peritonitis, a perforated hollow viscus. The culprit organism in SPP,
That's going to be E. coli. What's the diagnostic criterion for SBP? Acidic PMN count of 250 or more. Gold standard imaging, contrast CT abdomen. Best treatment for an intra-abdominal abscess, percutaneous drainage. Gold standard diagnosis of ACS, bladder pressure measurement. Definition of ACS, intra-abdominal pressure greater than 20 plus new organ dysfunction. Treatment for ACS, decompressive laparotomy. What's the absolute cornerstone of peritonitis treatment? Never forget this one, source control plus antibiotics. And the most common cause of postoperative small bowel obstruction, adhesions.
Finishing strong with a mesentery and omentum. The most common cyst is chyolymphatic, which classically presents as a painless abdominal mass, or sometimes with chronic pain. The gold standard imaging is a contrast CT, and definitive treatment is complete surgical excision. Remember the great mimic? Omental infarction looks exactly like appendicitis. The best treatment for an uncomplicated infarction is actually just conservative management, but you operate if there's diagnostic uncertainty or complications. For stable mesenteric trauma, it's CT-guided assessment and observation, but unstable trauma, that means an emergency laparotomy. Finally, what's the ultimate goal of mesenteric cyst surgery? Complete excision to prevent recurrence. Section 1, Investigations and Management. Let's get started. Okay, look at the pattern here in our investigation ladder. It's actually pretty striking. You'll notice that ultrasound is basically your best friend right out of the gate for almost everything, right? Whether you're looking at an abscess, a heighted head cyst, or suspected portal hypertension. But watch how your gold standard definitively shifts based on the actual pathology. For liver abscess, you've got to get a contrast CT. If it's a heighted cyst, you're pairing that CT with serology. Now, for hepatocellular carcinoma, or HCC, you're starting with an ultrasound and alpha-fetoprotein, sure, but your definitive test is always a triphasic CT or MRI. For liver trauma, you might do a fast scan at the bedside first, but if that patient is stable, they definitively need that contrast CT. Meanwhile, portal hypertension requires moving from an initial ultrasound Doppler straight to an endoscopy to check for varices. And finally, acute liver failure, you shift from checking basic LFTs and INR to a deeply cause-specific workup.
And honestly, this right here is a brilliant illustration of how we escalate care across the board. Literally every entry on this list is a potential exam question. Let's walk through it. For standard liver abscesses, you do IV fluids and broad-spectrum antibiotics initially, definitively moving to percutaneous drainage or even surgery. But notice those subtypes. Amoebic abscesses start with metronidazole and typically only need drainage if they rupture or just don't respond. Pyogenic abscesses, they require antibiotics, followed almost always by percutaneous drainage. For hydatid cyst, you start with albendazole before moving to pear or surgical cystectomy. For HCC, you have to optimize nutrition and staging first before deciding on resection, ablation, or transplant. Trauma just follows standard ATLS protocols initially, leading either to non-operative management or surgery. Portal hypertension starts with beta blockers, and definitive care means a TIPS procedure or a shunt. Now look down at esophageal variceal bleeds. This is absolutely crucial. You must always resuscitate, give terleprosine, and administer antibiotics initially, before moving to definitive band ligation or a TIPS procedure. Acute liver failure demands immediate ICU care leading up to a transplant. And benign tumors, well, they simply require observation unless they become symptomatic, which then prompts a resection.
Moving on to Section 2, Hepatocellular Carcinoma Deep Dive.
Now, you absolutely have to lock this rapid TNM staging in your memory. A T1 tumor, that's solitary. But here's the real kicker, the aha moment you need for the exam, distinguishing T2 from T3. T2 is either a solitary tumor with vascular invasion, or it's multiple tumors that are all less than or equal to 5 centimeters. The literal second you have multiple tumors and they cross that 5 centimeter cutoff, boom, you are in T3 territory. T4 indicates major vascular invasion or invasion of adjacent organs. And rounding the whole thing out, N0 to N1 dictates your regional lymph node involvement, while M0 to M1 flags your distant metastasis status.
So why does all that matter? Because that staging seamlessly dictates your management. Early stage HCC without cirrhosis simply gets a resection or ablation. But if they have early HCC with underlying cirrhosis and they fit perfectly into the Milan criteria, well, that buys them a literal ticket to a liver transplant, not just a resection. As we move down the list, intermediate stage patients undergo transarterial chemoembolization, or TACE. Advanced stage requires systemic options, think immunotherapy or targeted therapy, and terminal stage shifts purely to best supportive care.
Let's walk through this HCC clinical algorithm chronologically. It's super helpful to see it laid out like this because it builds a perfect mental framework. First, you spot the liver mass, or you note the cirrhosis. Next, you draw the alpha-fetoprotein. Then, you secure your triphasic imaging. Step 4 is absolutely critical. you must assess the patient's actual liver function using the Child-Pugh or MELD scores. It's only after gathering all this anatomical and physiological data that you take it to the multidisciplinary team to finalize the treatment plan.
Let's head into Section 3, Surgical Timelines and Classifications.
All right, step into the OR with me. For a liver resection, you've got to systematically secure your operative field. You mobilize the liver first, then you control that inflow, often utilizing a Pringle maneuver if you need it, before you even think about transecting the parenchyma. Once the transection is done, you achieve meticulous hemostasis and leave a drain in selected cases. This methodical sequence is what minimizes blood loss and ensures perfect visibility.
Now, flip that for a liver transplant. It follows an incredibly strict vascular sequence. After the recipient hepatectomy, you build the new connections from the outflow backwards to the inflow. You start with the IVC and hepatic vein anastomoses, then you move to the portal vein, followed by the hepatic artery, and finally, you reconstruct the bile duct. Outflow, inflow, biliary. It's a simple, completely logical sequence.
Examiners absolutely love to trap you on this slide because it forces you to separate the distinct practical purposes of these scoring systems. Child-Puff grades liver function into classes A, B, or C. MELD, on the other hand, dictates liver transplant priority. The AST system grades liver injury severity from 1 to 6. Now, pay close attention to BCLC compared to TNM. BCLC uniquely dictates both HCC staging and the resulting treatment, whereas the TNM system, that's used purely for anatomical HCC staging.
Section 4, Palliation and Rapid Differentiation.
Palliative care is heavily tested. You have to intuitively match the clinical problem to the best palliation. Pain, that follows the standard WHO analgesic ladder. Ascites requires diuretics and therapeutic paracentesis. Moving down, obstructive jaundice gets biliary drainage or stenting. A variceal bleed in a palliative setting still warrants band ligation or potentially a TIPS procedure. Advanced HCC gets systemic therapy, while a patient with an overall poor performance status transitions entirely to best supportive care. Okay, here is a classic differentiator that pops up literally everywhere. When looking at abscesses, the trick question relies entirely on treatment response. Amoebic abscesses will typically just melt away with medical management alone, specifically metronidazole. Pyogenic abscesses, on the other hand, almost always require physical percutaneous drainage to actually clear the infection. Trauma decision-making here is a purely binary choice. A hemodynamically stable patient with a liver injury gets non-operative management, period. End of story. But if that patient is unstable, that buys them an immediate trip to the operating room for an emergency laparotomy. Please, whatever you do, do not mix these two up on test day. Child-Pugh categorizes the severity of the liver dysfunction into those broad A, B, or C classes. The MELD score, however, is a strict numerical value. It was designed specifically to prioritize patients fairly on the liver transplant waiting list based on their actual mortality risk.
Let's rapidly differentiate our liver tumors. Always remember that hemangiomas are the most common benign tumors in the liver. This contrasts sharply with HCC, which is the most common primary malignant tumor. But don't fall for the classic trap here. Metastases are actually the most common malignant liver tumors overall. Secondary deposits totally outnumber primary liver cancers big time.
And finally, Section 5, High-Yield Exam Pearls.
Let's fire through these rapid associations. We just covered the tumors, but note that the most common cause of HCC worldwide is cirrhosis, specifically from hepatitis B and C. Your go-to tumor marker is AFP, and your absolute best imaging is the triphasic CT or MRI. For an amoebic liver abscess, the culprit organism is Entamoeba histolytica, and your drug of choice, that's metronidazole.
Rounding out our pearls for this explainer, you should know that E. coli is a super common organism in polymicrobial pyogenic abscesses. For any abscess, start with an ultrasound, but rely on a contrast CT as your gold standard. We know stable trauma means non-operative management, and unstable means an emergency laparotomy. And for those variceal bleeds, your first line is resuscitation, terlipressin, antibiotics, and band ligation. If that whole shebang fails, TIPS is your ultimate rescue maneuver.
We've brought this up a couple of times, but let's just be crystal clear. The Pringle maneuver is your foundational rescue move in the OR. You clamp the portal triad, which occludes the hepatic artery and portal vein to stop massive hepatic hemorrhage. Crucially, if you apply Pringle maneuver and the liver is still bleeding heavily, well, you instantly know the bleeding is coming from the hepatic veins, not the inflow. It's a real game changer for diagnostic control. So starting with Section 1, Diagnostics and the Investigation Ladder.
Notice the massive theme here right off the bat? Ultrasound is almost always your initial move. For uncomplicated gallstones and acute cholecystitis, ultrasound is both your starting point and your gold standard. But you really need to watch how this pathway changes as the disease progresses. For choledocholithiasis, you're starting with LFTs and an ultrasound, sure, but you'll need an MRCP or EUS for definitive diagnosis, and an ERCP for the actual therapeutic extraction. Contrast that with acute cholangitis, which escalates straight to therapeutic ERCP as the absolute gold standard. Now, if you suspect gallbladder cancer, that initial ultrasound must be followed up by a contrast CT or MRI plus histopathology. And for a bioleak, a HIDA-scan or ERCP is going to serve as your gold standard after the initial imaging.
Moving on to Section 2, Clinical Management and Palliation. Examiners love to test your timing here, so you've got to burn this into your memory. Simple biliary colic? That just gets analgesia and antiemetics initially, followed up by an elective lap chole. But if that evolves into acute cholecystitis, you need ABCs, IV fluids, antibiotics, and crucially, an early laparoscopic cholecystectomy, ideally within 72 hours. Now, choledocholithiasis requires IV fluids and an ERCP stone extraction before you even think about taking the gallbladder. Acute cholangitis, though, is an absolute emergency. We're talking ABCs, broad-spectrum antibiotics, and an urgent ERCP for biliary drainage. For gallstone pancreatitis, keep them supported initially, but you have to ensure they get a same-admission cholecystectomy to prevent it from happening again. Looking at the more serious complications now, see how a simple mucocele or hydrops just needs supportive care, followed by a standard cholecystectomy, but the moment you suspect an empyema or a gallbladder perforation, your management drastically changes. Empyema requires antibiotics and either an emergency cholecystectomy or a temporizing cholecystotomy tube. Perforation demands immediate resuscitation and emergency surgery. If you're dealing with gallbladder carcinoma, that requires careful nutritional optimization and staging before attempting a radical cholecystectomy. And Merizi syndrome, which is where a stone in the cystic duct actually compresses the common hepatic duct, well, that needs antibiotics if infected, followed by a cholecystectomy with a possible common bile duct repair. All right, Section 3, Surgical Timelines and Cancer. So, if a patient presents with classic red flags, like a right upper quadrant mass and painless jaundice, this is your exact flowchart for the gallbladder cancer workup. You start non-invasively, right, with an ultrasound. You then stage them systemically with a contrast CT or MRI. If there happens to be a biliary obstruction, you map it out with an MRCP. And this next step brilliantly illustrates modern surgical practice. You never, ever cut before discussing the patient at the MDT, the multidisciplinary team meeting. Yes, that literally means talking to the oncologist and radiologist to make the right call between surgery or palliation. Now, if an examiner asks you to walk through a laparoscopic cholecystectomy, you recite this exact timeline. You place your ports, you begin the dissection of Collat's triangle, and then you emphatically stress achieving the critical view of safety, or CVS. You must state this out loud to prove you are a safe surgeon. Only after that CVS is clearly achieved do you clip and divide the cystic duct and artery, and finally remove the gallbladder. You can contrast that surgical approach with an endoscopic ERCP timeline. First, you cannulate the ampulla just to gain access. Then you shoot your cholangiogram to map out the exact anatomy of the biliary tree. Next up, you perform a sphincterotomy to widen the opening, which lets you extract the stone and achieve clearance. Finally, you leave a stent in place if there's any lingering concern at all for obstruction or swelling.
Let's dive right into gallbladder cancer staging. You really just follow the anatomical depth from top to bottom. T in situ is strictly mucosal. T1A invades the lamina propria, while T1B reaches into the muscle layer. T2 pushes further into the perimuscular connective tissue. T3 actually breaches the serosa or directly invades the liver. And T4 is massive, wrapping the main portal vein, hepatic artery, or invading multiple organs. M0 to N2 covers your regional lymph nodes, and M simply tells you if there's any distant metastasis. And here is exactly why knowing that T&M staging matters so much clinically. If pathology returns as T1A, meaning it's confined to the lamina propria, a simple cholecystectomy is curative. But the absolutely crucial point is this. If that tumor touches the T1B muscle layer or deeper, you must escalate to a radical cholecystectomy. That means going back in to resect liver segments 4B and 5, along with doing a regional lymphadenectomy. T4 or M1 disease generally means we are looking at palliative therapy instead. When a T4 or M1 patient is unfortunately unresectable, your goal shifts entirely to symptom control and palliation. If they have obstructive jaundice, you relieve it with an ERCP and a biliary stent. You manage their pain aggressively, utilizing the WHO analgesic ladder.
If they happen to develop cholangitis, they need ERCP drainage to clear that infection. Systemic chemotherapy is offered for metastatic disease in fit patients, but if their performance status is poor, best supportive care is really the most appropriate and humane path forward.
Section 4. Classifications and rapid differentiations. First up, you've got to memorize these key name-to-disease associations. When you hear the Tokyo guidelines, immediately think acute cholecystitis severity, graded 1 through 3. Maritzi, types 1 through 5, describes the extent a gallstone erodes into the common hepatic duct. Strasbourg maps out iatrogenic bile duct injuries. Bismuth is used specifically for classifying bile duct strictures. And of course, as we literally just covered, TNM is for gallbladder cancer staging.
Now let's quickly apply these to some clinical vignettes. If the patient has right upper quadrant pain that lasts a few hours and then completely resolves, well, it's just biliary colic. The stone simply fell back into the gallbladder. But if that pain is persistent for hours on end and they suddenly spike a fever, that stone is stuck. The condition has officially evolved into acute cholecystitis.
Let's take it a step further and compare cholecystitis to cholangitis. Localized right upper quadrant pain simply means the gallbladder itself is inflamed. But the very moment jaundice joins that right upper quadrant pain and fever to form Charcot's triad, that means the stone is in the main duct and the entire biliary tree is infected. It's a simple but absolutely vital distinction to make. Choledocholithiasis is mechanically just stone sitting in the common bile duct. The patient might be jaundiced, sure, but they aren't toxic. Add an ascending bacterial infection to that blockage, though, and you have life-threatening cholangitis. Please never confuse your acronyms on the wards. MRCP uses MRI technology. It is a brilliant, entirely non-invasive diagnostic picture of the biliary tree. ERCP, on the other hand, uses an endoscope. It is an invasive therapeutic procedure to actually cut the sphincter and physically remove the obstruction. And returning briefly to our cancer surgery rules, remember that a simple cholecystectomy takes just the gallbladder right at the cystic duct margin. A radical cholecystectomy aggressively takes adjacent liver tissues, specifically those segments IVB and V, and completely clears out the regional hepatoduodenal lymph nodes. Okay, final stretch. Section 5. The ultimate exam pearls. These classic associations are the absolute bread and butter of surgical exams. The most common stones? Cholesterol, driven by the 4 Fs. Female, fat, 40, and fertile. Your go-to investigation is always an ultrasound, and the gold standard fix is the lap chole. If you catch inspiratory arrest upon palpation, that's Murphy's sign. Think acute cholecystitis immediately. And always watch for the deadly progression. Charcot's triad of pain, fever, and jaundice signals cholangitis. But add hypotension confusion, and you have Reynolds pentad. That signals septic shock, which demands an urgent ERCP. And again, just to hammer it home, MRCP is for diagnosis, ERCP is for the treatment of CBD stones. Finishing strong here, you simply cannot pass Eviva without mentioning the critical view of safety, because the most common bile duct injury site is right near Kalot's triangle. The most common overall complication of gallstones is acute cholecystitis. If a radiologist reports Rigler's triad, which is pneumobilia, a small bowel obstruction, and an ectopic stone, you are looking at gallstone ileus. Spot a calcified porcelain gallbladder, you have to resect it due to the increased carcinoma risk. Remember your staging rules. T1A buys a simple chole, while T1B or higher demands a radical chole. For gallstone pancreatitis, if it's mild, they get a same-admission cholecystectomy. But if they also have cholangitis, you do an urgent ERCP decompression first and take the gallbladder later.
Section 1. Classifications and Initial Management, the Foundation.
Let's map out our immediate action plan for these pancreatic presentations. Think of this like a giant matrix you just need to lock into your brain. First up, inflammatory conditions like acute and gallstone pancreatitis. Your immediate focus here is purely resuscitation. We're talking ABCs, aggressive IV fluids, analgesia, and making them NPO. Then, you move to definitive cause-specific care like an ERCP or an early cholecystectomy during that same admission if it's mild. Now, if things get nasty and you're dealing with infected necrosis, hit them with antibiotics and support right out of the gate. But for definitive management, you are using the step-up approach. Drain it first, then necrosectomy if needed. What about a pseudocyst? Well, initial management is just observation if they're asymptomatic. You only go in for endoscopic or surgical drainage if they get symptomatic, if it's larger than 6 centimeters, or if it hangs around longer than 6 weeks. For chronic pancreatitis, start with analgesia and enzymes, stepping up to drainage or resection definitively. Moving to cancer,
Optimize their nutrition and get them staged early so you can prep for definitive Whipple or distal pancreatectomy with or without chemo. Trauma, always strictly adhere to ATLS protocols initially before you even think about operative repair. And finally, for a fistula, focus on fluids, nutrition, and placing a drain, escalating to endoscopic or surgical management if it just won't close.
You know, examiners literally love to test if you understand exactly why you're using a specific scoring tool, so don't mix these up. The Revised Atlantic classification, that is strictly for grading clinical severity into mild, moderately severe, and severe. Balthazar, on the other hand, is used specifically to grade CT imaging findings from A to E. What about BISAP? That's your tool for early severity prediction. Ranson criteria, that's the absolute classic standard for determining a patient's prognosis. And finally, the AST scale is your go-to for grading pancreatic trauma from grade 1 up to V.
Section 2. Investigations in cancer workup. Finding the pathology.
Okay, so you absolutely must know the difference between the very first test you order and the true gold standard test. For acute pancreatitis, you start by checking serum lipase or amylase, right? But the gold standard is actually a contrast-enhanced CT. Crucially, though, you have to order it after 72 hours. For chronic pancreatitis, start with a basic CT of the abdomen, but the gold standard relies on an MRCP or sometimes ERCP for selected cases. If you suspect a pseudocyst, start cheap and non-invasive with an ultrasound, but you'll confirm it definitively with a contrast CT. For pancreatic cancer, your initial move is a contrast CT using a dedicated pancreatic protocol. But to get that gold standard tissue diagnosis, you absolutely need an endoscopic ultrasound, an EUS, with an FNA biopsy. And lastly, for trauma, a standard CT abdomen gets you going. But to truly prove there's a duct injury, you again have to rely on an ERCP or MRCP.
So, imagine a patient walks in with painless jaundice and unexplained weight loss. The clinical pathway here is strictly linear. Step 1, you draw LFTs and that CA19-9 tumor marker. Step 2, you immediately move to staging with a pancreatic protocol CT and a CT chest. Once you've got that imaging in hand, step 3 is securing a tissue diagnosis via EUS with FNA. Then, step 4, all of this highly detailed data goes directly to a multidisciplinary team review, which leads us to step 5, finalizing the definitive treatment plan.
All right, Section 3, Cancer Staging and Palliative Care, the Oncology Matrix. Let's rapidly break down the T&M criteria. Tumor size essentially dictates the T stage. T1 is 2 centimeters or less, T2 is between 2 and 4 centimeters, and T3 is anything greater than 4 centimeters. But listen up, pay very close attention to T4. T4 means there is major arterial involvement. That is a huge red flag, because it universally renders the tumor unresectable. For the rest, the N stage maps out regional lymph nodes from N0 to N2, and M indicates metastasis. M0 for none, M1 for distant spread.
So how does that T&M staging actually dictate our surgical plan? Well, it sets our boundaries. If the cancer is resectable, the pathway is straightforward. Surgery followed by adjuvant chemotherapy. If it's borderline resectable, we actually flip that script. We utilize neoadjuvant chemotherapy, maybe with some radiotherapy, to shrink the tumor before we attempt surgery. If it's locally advanced and unresectable, we're relying purely on chemo and radiotherapy. And if it's metastatic, the focus shifts entirely to palliative chemotherapy.
The really crucial takeaway here is that when a cure just isn't possible, we don't just throw our hands up and give up. We target specific palliative problems with highly effective, exact interventions. For example, if the patient has obstructive jaundice, you do an ERCP with a biliary stent. If the tumor is causing a gastric outlet obstruction, you bypass it with a gastrojejunostomy or throw in a duodenal stent. For severe pain, you escalate up the WHO analgesic ladder and utilize a celiac plexus block. Malnutrition gets treated aggressively with pancreatic enzymes and nutritional support. Metastatic disease obviously warrants systemic chemo, but remember, if the patient has a very poor performance status, the most appropriate and ethical path forward is simply best supportive care.
Section 4. Surgical timelines and procedures. Let's step into the operating room.
The monumental Whipple procedure, or pancreaticoduodectomy. Let's walk through it. We begin with cauterization. That's mobilizing the duodenum to thoroughly assess resectability. Once we're cleared, we enter the massive resection phase. We're removing 5 key structures here: the head of the pancreas, the duodenum, the common bile duct, the gallbladder, and sometimes even the distal stomach. Once all that is out, we essentially have to rebuild the patient's GI tract through 3 vital reconstructive anastomoses. First, the pancreatic jejunostomy, then the hepaticojejunostomy, and finally, the gastrojejunostomy.
Now contrast the complexity of the Whipple with a distal pancreatectomy, which we use for tumors located in the body or tail. Here, you mobilize the distal pancreas,
carefully control and ligate the splenic vessels and resect the tissue, often actually taking the spleen right along with it, depending on the pathology. Finally, you secure and completely close the pancreatic stump to prevent any postoperative fistulas.
All right, Section 5, Rapid Differentiation in Pearls. Welcome to the Viva Lightning Round. So I have to ask, are you ready for the Viva? When an examiner fires these clinical scenarios at you, can you rapidly differentiate the most commonly tested pancreatic pathologies? Let's find out right now. Let's run through 5 key pairs you absolutely must be able to contrast instantly. First, acute versus chronic pancreatitis. Acute is reversible inflammation, chronic is irreversible fibrosis. Next, sterile versus infected necrosis. Sterile has no infection, while infected is confirmed by seeing gas on a CT scan or getting a positive culture. Distinguishing fluid collections. A pseudocyst is a collection of sterile fluid, whereas an abscess is full of pus and active infection. For oncology, cancers in the head of the pancreas present early with jaundice, but cancers in the tail, those have a late, often silent presentation. And finally, your scopes. An ERCP is a therapeutic intervention, while an MRCP is purely a diagnostic imaging tool.
All right, lock these rapid-fire pearls in. For etiology, remember, gallstones are your most common cause of acute pancreatitis, followed closely by alcohol. Diagnostically, serum lipase is absolutely your best enzyme to order. Confirming that diagnosis requires just 2 out of 3 criteria: typical pain, elevated enzymes at least 3 times the upper limit of normal, or characteristic imaging. Speaking of imaging, your gold standard is a contrast-enhanced CT, but remember, you have to wait 72 hours after symptom onset to accurately assess necrosis. When it comes to complications, the pancreatic pseudocyst is the most common local issue. If you run into infected necrosis, always utilize the step-up approach. Mild gallstone pancreatitis? The standard of care is a same-admission cholecystectomy. And if they present with gallstone pancreatitis complicated by cholangitis, they need an urgent ERCP.
Let's finish up this data dump. When grading severity, the revised Atlanta classification defines severe acute pancreatitis strictly as persisting organ failure lasting more than 48 hours. Shifting back to oncology, getting a gold standard tissue diagnosis relies on an EUS-guided FNA, and you should always check that CA19-9 tumor marker. Ductal adenocarcinoma is your most common cancer, and it's usually hiding right in the head of the pancreas. Its classic textbook presentation: painless, progressive, obstructive jaundice, often accompanied by Courvoisier sign, which is a palpable, non-tender gallbladder. Finally, definitive operations. If the cancer is in the head, you do a Whipple. If it's in the body or tail, a distal pancreatectomy is the answer.
All right, Section 1. Let's start at the top with the upper GI tract, specifically the esophagus and stomach.
There's just a massive amount of testable information packed in here. So, the esophagus. It's roughly 25 centimeters long, running from C6 down to T11. But listen, the thing you really need to look out for are the 4 constrictions. You've got the cricopharyngeus at C6, the aortic arch at T4, the left main bronchus at T5, and the diaphragm at 10. Examiners absolutely love these 4 choke points, especially when they're asking about foreign body impactions. Blood supply, that's coming from the inferior thyroid, the aorta, and the left gastric arteries, with lymph draining to cervical, mediastinal, and left gastric or celiac nodes. And do not forget, the lower esophagus is a major portosystemic anastomosis site. That is literally why esophageal varices form. Okay, moving down to the stomach, we all know the parts: cardia, fundus, body, antrum, and pylorus. It's got a super rich blood supply from the left and right gastric, left and right gastroepiploic, and short gastric arteries. All that venous blood heads straight to the portal vein, and lymph goes to the celiac nodes. Oh, and quick spatial pearl, what's sitting right behind the stomach? The lesser sac. Never forget that posterior relation.
Moving along, we hit a really crucial clinical landmark, the ligament of Treitz. This marks the duodenojejunal or DJ junction. Why do we care? Because it is the strict anatomical dividing line between upper and lower GI bleeds. As for the duodenum itself, it's also 25 centimeters long, broken into 4 parts. The first part is your classic peptic ulcer site. The second part is where the biliary magic happens. It receives both the common bile duct and the pancreatic duct at the major papilla. And you've got to watch out for the third part. It is crossed anteriorly by the superior mesenteric artery and vein. Forgetting which vessels cross that third part? Man, that is a classic exam trap, so lock that one in.
Okay, moving right along into Section 2. We're heading into the lower GI tract, taking us from the intestines all the way down to the anal canal.
Now, being able to visually differentiate the jejunum from the ileum is an absolute must-have skill in any open abdominal surgery. So what are we looking for? The jejunum gives you a thick wall, a wide lumen, and long vasa recta, but very few arterial arcades and overall less mesenteric fat. Compare that directly to the ileum. The ileum's got a much thinner wall, a narrower lumen, and short vasa recta, but it makes up for it with tons of arcades and a lot more fat creeping up onto the bowel wall. Plus, it houses Peyer's patches for immune function. So if you're holding a loop of bowel, check that fat distribution and blood supply to know exactly where you are.
Let's transition to the large intestine, starting with everyone's favorite, the appendix. Surgically, how do you find it? Easy. You follow the 3 Taenia coli of the colon. They converge directly at the base of the appendix. Its surface marking is the famous McBurney point, and the most common position is retrocecal. But here is the major takeaway. The appendicular artery is an end artery. If that vessel gets compressed by inflammation, the appendix goes ischemic and ruptures. Boom. Looking at the colon more broadly, remember the midgut is supplied by the SMA and the hindgut by the IMA. You'll recognize the colon by its Taenia coli, haustra, and those little fat tags, the ependyces epiploicae. Finally, drill these 2 watershed areas into your brain right now. Griffith's point at the splenic flexure and Sudek's point at the rectosigmoid junction. These are high-risk ischemic zones because their arterial supply is, well, pretty tenuous.
Dropping all the way down into the pelvis, we have the rectum at about 12 to 15 centimeters long, leading into the 4-centimeter anal canal. And this brings us to the dentate line. Guys, this is the ultimate dividing line for innervation and hemorrhoids. It is arguably the most important anorectal landmark you'll face in Aviva. Above the dentate line, you've got visceral innervation, which means it's painless. You'll find internal hemorrhoids here, and blood drains via the superior rectal vein, which, remember, is another major portosystemic anastomosis. Below the dentate line, a completely different story. You have somatic innervation, meaning it is exquisitely painful. This is where external hemorrhoids live, and venous drainage goes through the middle and inferior rectal veins directly into the systemic circulation.
All right, section 3. Let's shift our focus to the right upper quadrant and tackle the hepatobiliary system, the liver and the gallbladder.
So the liver is the largest gland in the body, functionally broken down into 8 count-and-out segments. This specific segmental anatomy is exactly what allows surgeons to do those precise, localized resections. Now, the blood supply here is famously counterintuitive. You'd normally think the artery does the heavy lifting, right? Not here. The portal vein actually provides 75% of the blood flow, while the hepatic artery brings in only 25%. Everything eventually drains out through the hepatic veins straight into the IVC. At the porta hepatis, you'll find the portal triad: the portal vein, hepatic artery, and bile duct. Oh, and don't forget the liver's bare area. It's a spot totally devoid of peritoneum, sitting in direct contact with the diaphragm.
Okay, if you take a mental photograph of just one concept today, make it Cowlitt's triangle. Properly identifying this and getting that critical view of safety is literally the single most important step in a safe cholecystectomy. The boundaries? You've got the cystic duct laterally, the common hepatic duct medially, and the inferior border of the liver superiorly. Right inside this triangle sits the cystic artery, usually branching off the right hepatic artery. The gallbladder itself holds about 30 to 50 mils and is divided into the fundus, body, and neck. That neck area is also known as Hartmann's pouch, and it is exactly where gallstones just love to get impacted. Let's make this static anatomy a bit more dynamic and just trace the flow of bile. Step 1. Bile flows out of the liver as the right and left hepatic ducts join up to form the common hepatic duct. Step 2. This common hepatic duct meets the cystic duct coming from the gallbladder, and together they form the common bile duct, or CBD. Step 3. The CBD travels down, joins forces with the main pancreatic duct, and they both empty right into the second part of the duodenum at the ampulla of Vater, specifically at the major duodenal papilla. And all of this flow is strictly regulated by the sphincter of Oddi.
Moving into section 4, we're taking a look at the retroperitoneum and the left upper quadrant to cover the pancreas and the spleen.
The pancreas is situated quite uniquely. You've got the head, neck, body, and tail. The head sits incredibly snug right inside that C-loop of the duodenum we mentioned earlier. Then there's the uncinate process, a little hook that passes directly behind the superior mesenteric vessels. But listen up, here is the most dangerous neighborhood in this whole region, the tail of the pancreas. It lies right inside the splenorenal ligament. This is a classic high-yield board question because it is so incredibly easy to accidentally injure the pancreatic tail during a splenectomy. Quick naming check before we move on: the main pancreatic duct is Wirsung, and the accessory duct is Santorini.
Sliding over to the spleen,
It sits neatly protected by the 9th, 10th, and 11th ribs on the left. Why does that matter? Because any trauma to those specific ribs is a massive red flag for a splenic rupture. It's anchored by the gastrosplenic and splenorenal ligaments. Blood comes via the splenic artery, which is famously tortuous like a winding river. Functionally, it's split into white pulp for immune duties and red pulp for RBC destruction. And here's a massive surgical pearl for you. About 10% of people have an accessory spleen. If you're doing a splenectomy for something like ITP and you leave an accessory spleen behind, your patient's disease is going to relapse for sure.
Section 5. Let's drop down to the abdominal wall and sort out inguinal and femoral hernias. Guaranteed exam points right here.
Okay, the absolute key to differentiating a direct from an indirect inguinal hernia comes down to their relationship with one single landmark, the inferior epigastric vessels. A direct hernia pushes straight through the abdominal wall, medial to the inferior epigastric vessels, going right through a weak spot called Hesselbach's triangle. On the flip side, an indirect hernia enters the deep inguinal ring, which sits lateral to those vessels and travels its way down the inguinal canal. Just to keep the ring straight, the deep ring is lateral to the inferior epigastrics, while the superficial ring is just an opening in the external oblique aponeurosis.
Let's keep this one brief but impactful. The femoral hernia. Anatomically, it's located below the inguinal ligament, pushing down into the femoral canal. But the one thing you must take away is its clinical severity. Because the femoral ring has such narrow, rigid borders, a femoral hernia carries the absolute highest risk of strangulation out of all these groin hernias. If a case study mentions this, you need to be thinking high risk immediately.
And finally, Section 6. This is our ultra-high-yield landmarks and pearl segment, the ultimate rapid-fire checklist before an exam.
Let's rapid-fire some general pearls. The longest part of the entire GI tract, the small intestine. The narrowest part of the esophagus, making it the most common spot for a swallowed coin to get stuck, the cricopharyngeus at C6. Where exactly is the physiological lower esophageal sphincter? Right at the gastroesophageal junction. And let's use a little spaced repetition here. What are your major portosystemic anastomosis sites? The lower esophagus, the rectum, and the umbilicus.
Next up, structural landmarks. You need to instantly link these anatomical names to their surgical significance. In the liver, the porta hepatis houses your portal triad: portal vein, hepatic artery, and hepatic duct. In the biliary system, Collat's triangle is your zone for safely identifying the cystic artery. The ampulla of Vater, that's the vital junction where the common bile duct and the pancreatic duct finally meet up. And down on the abdominal wall, Hesselbach's triangle should immediately scream direct inguinal hernia to you.
Finishing up our tables with the colon and duodenum. If you trace the 10 E. coli, they will definitively lead you right to the base of the appendix, generally around McBurney's point. For colonic blood supply, your two massive watershed danger zones are Griffith's point at the splenic flexure and Sudic's point at the rectosigmoid junction. And lastly, the ligament of Treitz in the duodenum. This is your absolute clinical marker for dividing upper from lower GI bleeds, as well as the embryonic divider for the foregut and midgut. Fantastic job, we've essentially crushed every single high-yield point from our notes.
Section 1. Investigations and clinical workup. You know, the clock starts ticking the very second a patient walks in with a groin swelling.
Let's walk through this investigation ladder together, row by row. Notice how clinical examination is the absolute anchor here. For a standard groin hernia, your initial investigation and your gold standard are both exactly the same, a solid clinical exam. But if you suspect an occult hernia, one hiding beneath the surface, you start with an ultrasound. If you're still scratching your head, the MRI is your gold standard fallback. Now, for those large incisional hernias, you start clinical, but you're going to need a CT of the abdomen for that gold standard mapping. And what if it's strangulated? Well, your initial investigation is clinical, and your gold standard is immediately rushing them to surgery. The scalpel is your definitive diagnostic tool there.
I want you to really lock this in. Here is your foundational exam pearl. It sounds so incredibly simple, but I promise it'll save you on test day. Hernia is primarily a clinical diagnosis. Don't let an examiner bait you into ordering a bunch of fancy, unnecessary advanced imaging for a straightforward, uncomplicated growing bulge.
And this brilliantly illustrates the exact algorithmic thinking you need on the ward. Patient comes in with a groin swelling, right? Step 1, history and examination. Step 2, you ask yourself, is it reducible? Can I push it back in? If yes, great, you can take a breath. It's an elective repair. But if the answer is no, you immediately pivot and look for signs of obstruction or strangulation. If you see those red flags, you bypass the waiting list completely and go straight to emergency surgery.
That brings us right into Section 2, hernia management and triage. Once you've actually made the diagnosis, triaging correctly based on the hernia's exact state is, quite literally, life or death.
Let's break down this triage hierarchy. At the baseline, a reducible inguinal hernia just gets some initial analgesia and an elective referral for a definitive mesh repair. Nice and easy. But if it's irreducible, also known as incarcerated, the whole game changes. Initial management means making the patient NPO, so strictly nothing by mouth. You start IV fluids, and you might attempt gentle taxis, but only in very selected cases where there are absolutely zero signs of strangulation. The definitive move there is urgent surgery. Now, if it's obstructed, you need aggressive resuscitation, get an NG tube down, pump those IV fluids, and get to emergency surgery. And strangulated? Immediate ABCs. Airway, breathing, circulation. Pump fluids, hit them with broad-spectrum antibiotics, and rush straight to emergency surgery. And you better be ready for a bowel resection if that tissue turns out to be non-viable.
Now, what's really fascinating about this slide is how the specific hernia type dictates its own set of rules. Take femoral hernias. Because they have such a scary high complication rate, definitive surgical repair is always recommended, always. But contrast that with umbilical hernias. In adults, if it's small, you can just observe it. But if it becomes symptomatic or if it's bigger than 2 centimeters, you go for a mesh repair. Pediatric umbilical hernias, though, the strict rule is initial observation. You only intervene surgically if that hernia is stubbornly persisting beyond 4 to 5 years of age or if it gets complicated. And for incisional hernias, it's supportive care up front, leading eventually to a definitive open or lap mesh repair.
Let's just consolidate these management rules so they are completely second nature for you. Reducible, elective. Irreducible or incarcerated, that's an urgent repair. Obstructed, emergency surgery. Strangulated, emergency surgery, and be ready to do a bowel resection. The classification beautifully dictates your clinical urgency.
All right, let's step off the ward and scrub into the operating room. Section 3, operative timelines and approaches.
We're kicking off with the undisputed gold standard for elective inguinal hernia repairs, the open Lichtenstein tension-free mesh repair. Methodically, the timeline looks exactly like this. First, make your incision. Next, dissect carefully down to meticulously identify that hernia sac. Once you've got it, you either reduce it or excise it. Then comes the absolute critical step, placing the mesh to reinforce the posterior wall of the inguinal canal. Finally, close the wound. It's simple, it's elegant, and it works incredibly well.
Let's move over to the laparoscopic side of things, specifically the TEP, which is totally extraperitoneal, and TAPP, transabdominal preperitoneal repairs. See how this builds? You start with port placement. Then, and this is crucial, you do a preperitoneal dissection to actually carve out your working space. Once you're in there, you reduce the sac, lay down your mesh, use fixation if your specific patient scenario calls for it, and then close up. The big key addition to remember here is that complex preperitoneal dissection phase.
Okay, examiners absolutely love dropping classification names to see if you actually know what hernia they match up with, so let's fire through these. NIHUS, that's your groin hernia classification. Gilbert, specific to inguinal hernias. EHS stands for European Hernia Society, and they cover both inguinal and ventral hernias. Ventral hernias themselves are split into primary versus incisional. And the AAST classification? That one specifically grades abdominal wall injuries. Match the name to the hernia type, and you're snagging easy marks.
Of course, surgery isn't always textbook. We've got tricky, special situations to navigate. If a patient with an inguinal hernia is completely unfit for surgery, the accepted move is watchful waiting. Now, if you are dealing with a recurrent hernia, here is a golden rule. Utilize the opposite approach. If their first repair was open, you go in laparoscopically. If they had a lap repair initially, you do it open. It's brilliant. And what if you walk into a grossly contaminated field? You absolutely must avoid synthetic mesh. It's a huge red flag. In those scenarios, you have to pivot and consider a pure tissue repair or use a biologic mesh.
Section 4. Crucial anatomical differentiations. I'm picking up the pace here because this is the most anatomically dense phase of our explainer.
The secret to mastering this is rapid visual differentiation. So let's bounce between these comparisons. Direct versus indirect inguinal hernia. It literally all comes down to the inferior epigastric vessels. Direct is medial to them, indirect is lateral. Inguinal versus femoral. Look at the inguinal ligament. Inguinal is above it, femoral is below it. Reducible versus irreducible. Simply, can you push it back in or not? Obstructed versus strangulated. Obstruction is just a mechanical blockage of flow, but strangulation,
That means ischemia. The blood flow is choked off. And like we said before, TEP is your extraperitoneal approach, while TAPP is transabdominal.
Now, I really want you to visualize this and lock it in. Hesselbach's triangle. Picture the borders. The medial border is the lateral edge of the rectus abdominis muscle. The superolateral border is formed by the inferior epigastric vessels. The inferior border is the inguinal ligament. Remember, a direct hernia pushes straight through the floor of this exact triangle, meaning it is medial to the inferior epigastric vessels. An indirect hernia takes the scenic route down the inguinal canal, staying lateral to those exact same vessels.
Here is another massive exam pearl for you, the femoral canal boundaries. This is a rigid, completely unforgiving space, and its four borders are highly testable. Medially, you've got the lacunar ligament. Laterally, the femoral vein. Anteriorly, the inguinal ligament. And posteriorly, the pectineal ligament. Because these four borders have basically zero give to them, this canal is the exact reason why femoral hernias have such a notoriously high rate of strangulation.
All right, we've reached the climax of the explainer. Section 5, shift into maximum adrenaline, rapid-fire Viva mode. These are your high-yield exam pearls. Let's do this.
Eponymous hernias. These are guaranteed free points if you just memorize them. Richter's hernia. Only a portion of the antimesenteric bowel wall is trapped. The tricky part? You can get strangulation without complete bowel obstruction. Littre's hernia. The hernia sac literally contains a mecal diverticulum. Madel's hernia. This is that infamous W-shaped hernia. Two loops are in the sac, but the loop of bowel that's actually strangulating is trapped deep inside the abdomen. Sneaky, right? And a sliding hernia. This is where a retroperitoneal organ, usually the wall of the colon or the bladder, actually makes up part of the hernia sac wall itself.
Okay, let's pause. I'm going to throw a direct, double-barreled question at you. What is the most common hernia in females, and which hernia carries the absolute highest risk of strangulation? Think about it for just a second.
The answer to both is the femoral hernia. Do not get this wrong on test day. While inguinal hernias are the most common overall, the femoral hernia is an incredibly high-yield answer because it is the most common one specifically in females. And due to those ridiculously tight, rigid boundaries we just discussed, it carries the absolute highest risk of strangulation.
Let's blitz through the last of these stats. The most common abdominal wall hernia overall? Inguinal. The most common type of inguinal hernia? Indirect. The #1 cause of an incisional hernia? A wound infection. Your gold standard for diagnosis? We said it before, it's clinical examination. Your gold standard elective repair? The open Lichtenstein tension-free mesh. But your best option if it's bilateral or if it's recurrent, that's when you deploy the laparoscopic TEP or TAP approach.
I'm going to leave you with this final provocative thought. Picture this. You open up an emergency strangulated hernia, and you are staring down a grossly contaminated field. There's active infection everywhere. You know the golden pearl. Synthetic mesh is strictly contraindicated here. The real question is, are you fully prepared to pivot on a dime and execute a complex biologic or pure tissue repair when the pressure is on in the OR? Use these notes. Visualize the anatomy, lock in those algorithms, and I promise you will be ready for anything the exam or the operating room throws your way. Keep reviewing this explainer until it's second nature. Happy studying!